All right, welcome back to Chapter 39. We're going to be talking about geriatrics. Our overview is going to be the effects of aging on body systems, special geriatric assessment findings, an assessment-based approach in a geriatric patient. All right, our case study. EMTs arrive at the scene of a motor vehicle collision to find a single patient, a woman in her 80s, still sitting in the driver's seat. The car struck a utility pole and has moderate damage to the front end, and the airbags have deployed. Upon making contact with the patient, Vic finds that she is confused and unable to answer questions appropriately. With the exception of a few abrasions on her face, there are no immediately obvious signs of injury. What are the first actions of the EMT should take? How could the injuries received by be affected by the patient's age? And how are the body's responses to the injuries affected by the patient's age? I'm going to go back to the case study. All right, and there are the questions again. I encourage you to write them down so that you can try to answer them throughout the lesson. All right, introduction. The geriatric are at a greater risk for injuries and illness. The changing physiology of the geriatric body system results in a different presentation of signs and symptoms. The geriatric patient often has one or more long-term conditions that might require multiple medications. Okay, age-related physiological changes begin around age 30. People are living longer with chronic illness. Illness is common among the geriatric, but not inevitable. The aging body has fewer reserves for acute or severe with rapid onset medical and traumatic emergencies. Okay, so you can see the figure here. The neurological system, the brain changes with age. Clinical depression is common. Altered mental status is common. We see patients with dementia and Alzheimer's all the time. Cardiovascular system, hypertension is common. Changes in the heart rate and rhythm. Gastrointestinal, constipation is common. Deterioration of structure in mouth is common. General decline in efficiency of liver, impaired swallowing, malnutrition as a result of deterioration of small intestine. So the point is, throughout all these different systems, is that if we remember in lifespan development, as we're younger, our body is more susceptible to injury and illness. And then as we get to that median age between 30 and 50, we see our peak. And then after that, we start to deteriorate as we get older. It's an unfortunate life event, but it is the case. So be aware of that when you're treating or assessing your geriatric patients. But you can look over this and you can see the different deteriorations in each system at your own pace. Okay, the cardiovascular system. Stenosis of the heart valves can reduce blood flow and cause pulmonary edema. Excuse me. Cardiac hypertrophy can reduce cardiac output and affects the ability to compensate for illness and injury. There is a decreased ability to increase heart rate to meet demand. And we're going to define stenosis for you. It's just the abnormal narrowing of a passage in the body. So an abnormal narrowing of heart valves. And cardiac hypertrophy is the abnormal enlargement or thickening of the heart muscle, resulting in increases in cardiomyocyte size and changes in other heart muscle components such as extracellular matrix. Dysrhythmias may occur. That means there's abnormal rhythms, and electrical conduction is impaired. Arteriosclerosis increases the workload of the heart. Arteriosclerosis, if you remember, is a disease of the blood vessels, of the arteries. And the baroreceptors are less sensitive. Orthostatic hypotension may occur. The respiratory system: decreased strength of respiratory muscles, decreased pliability of the rib cage, decreased alveolar surface area, and chemoreceptors become less sensitive. A decreased smooth muscle decreases airflow to the alveoli. Weakening of cough reflex and decreased function of cilia increase the risk of infection. And to define cilia for you, is the, stand by for a second. They're like these little, I don't want to say they're moving. They're like little hairs. You can find them in the respiratory tract and in the middle ear. They have a rhythmic waving or beating motion, and they work to keep the airway clear from mucus and dirt, and help us breathe without irritation. You can look it up on Google. They're kind of like a plant almost, but you can look them up whenever you get a chance. All right. The neurologic system: decrease in brain mass with an increase in CSF volume. That is cerebral spinal fluid. Degeneration of neurons lead to the accumulation of plaques and tangles, which decrease nerve function. Reflexes slow down. Decreased ability to sense body position. Diminished vision and hearing. And decreased efficiency of autonomic functions. Sight changes. Well, I would hope they don't, but your geriatrics can experience cataracts, glaucoma, macular degeneration, and retinal detachment. Neuropathy affects motor sensory and autonomic nerve tract. Numbness, tingling, pain, swelling, weakness, and decreased pain perception may occur. Old people have trouble feeling pain. So if you do a pain scale and they tell you it's 1 or 2, don't be surprised, because it probably is a 1 or 2 for them. So neuropathy is basically the inability to feel pain, and that's why, especially in diabetics, that have an increase the risk of neuropathy. But they can't feel the pain as much as other people. All right, the GI system: deterioration in smell and taste, loss of teeth, decreased salivation, and changes in the stomach and esophagus can lead to malnutrition. The liver decreases in size, weight, and function. Peristalsis throughout the GI tract is involved. Is slowed. And peristalsis is the involuntary constriction and relaxation of the muscles of the intestine or other canals. So it's it's involuntary constriction and relaxation of the GI tract. The endocrine system: we know that these are the filters of our body. They produce hormones and such. There is an increased risk of type 2 diabetes. There is less efficient regulation of blood pressure, fluid balance, electrolyte balance, and beta sympathetic response. Decreased thyroid hormone decreases metabolic rate. That means old people can gain weight a lot easier. All right, musculoskeletal system. Osteoporosis weakens bones. Anytime we see osteo, we're talking about the bone structure. Loss of vertebral disc space with kyphosis. Kyphosis is mainly like that hunchback look. Modifications to spine motion restriction may be required. And there we go. They're patting the geriatric patient right there to help make them comfortable. Probably due to kyphosis. Okay, degeneration of joints, mainly cartilage and things like that, and a decreased range of motion, probably due to some inability to extend or maybe some pain, and decreased skeletal muscle mass. The renal system. Nephron loss with decrease in kidney mass, decreased renal blood flow and filtration rate, disturbances in fluid and electrolyte balance, and decreased clearance of drugs may result in toxicity. So a nephron is a functional unit of the kidney that consists of glomerulus and is associated tubule through which the glomerular filtrate passes before emerging as urine. So nephron is a defiltration system of the kidney, so that that will help filter the blood and turn it into urine. Apologize for my mispronunciations. All these things you can Google as well. All right, the integumentary system. The skin is thinner, looser, and more prone to injury, especially if you have old people who are on blood thinners, and their wounds heal slowly. All right, special geriatric assessment findings. Physiological changes make certain injuries and illnesses more likely. Pain may be diminished or absent. Physiological changes impair the ability to compensate for illness and injury. Assessment finding for chest pain or absence of chest pain. For an MI, instead of presenting with chest pain, an MI in a geriatric patient may be present as a silent heart attack, so they may not know that they're having a heart attack. The patient may present with weakness, fatigue, confusion, dizziness, nausea and vomiting, abdominal pain, syncope, or trouble breathing, but no pain. They may complain of aching shoulders or indigestion. Patients with chronic chest pain may be prescribed nitroglycerin, and follow protocols for assisting with nitroglycerin administration. We've already talked about your scope of practice when it comes to nitro. All right, an MI. If a heart attack is suspected with or without chest pain, follow protocols, consult with medical direction as needed, and transport. Congestive heart failure may be chronic or new onset. Backup of blood behind a weakened heart results in characteristic signs and symptoms. And here we go. Here's some signs and symptoms of CHF. Jugular vein distension, peripheral edema, altered mental status, fatigue or anxiety, wheezing, dyspnea, orthopnea, and tachypnea, crackling on auscultation and chest pain. So up at the top where it says jugular vein distension or JVD and peripheral edema means swelling probably in the ankles. And we're going to manage this patient with oxygen, keep them in the Fowler's position, sitting upright, transport them and assist in ventilations if we need to. Another way we can help manage this patient is with CPAP, especially if there's crackling in the lungs, meaning fluid in the lungs. Okay, shortness of breath. Common causes are pulmonary edema, pulmonary embolism, pneumonia, and COPD. Breathing can easily become inadequate. Okay, so we have our dyspnea in the middle, and we have all the things that could be going on. CHF, chronic bronchitis, pulmonary embolism, pneumonia, pulmonary edema, heart attack, asthma, and emphysema. Pulmonary edema, the left ventricle starts to eject less blood than the right. We're talking about the heart now, ejecting less blood on the left side than on the right. Excessive pressure in the vessels in the lungs results, and fluid leaks into the space between the alveoli and the capillaries. Gas exchange becomes inadequate. So the blood has to go somewhere, and if it's not getting ejected from the heart, then it's going back down into the lungs. All right, signs and symptoms, pulmonary edema, include severe respiratory distress, orthopnea, altered mental status, coughing, and blood-tinged sputum. Emergency care centers around respiratory support. Your emergency care centers around respiratory support. Pulmonary embolism usually occurs when a blood clot breaks free from veins of the lower extremities or pelvis and is transported back through the right side of the heart, eventually reaching the pulmonary arteries. Signs and symptoms: sudden onset of dyspnea, localized non-radiating chest pain, possible back or shoulder pain, weakness or syncope, and anxiety. To treat this, you would maintain the SpO2 greater than or equal to 94%, monitor for inadequate breathing, provide positive pressure ventilation if breathing is inadequate, transport the patient, request ALS if possible. Pneumonia, it can be bacterial, viral, or a fungal infection of the lungs. The geriatric are at an increased risk. The geriatric may not exhibit classic pneumonia signs, such as pain, high fever, and chills. Watch for severe respiratory distress and malaise. On that first bullet where it says it can be bacterial, viral, fungal, we just know that those things can cause pneumonia, which is fluid in the lungs that can cause a fever, become infected. But it's caused by certain things, the flu can cause it. We now have the new novel coronavirus that can cause it. So a lot of things that could cause pneumonia. Altered mental status and inadequate breathing may occur. Ensure adequate oxygenation. Consider CPAP if the patient cannot maintain the SpO2 greater than or equal to 94%. Provide positive pressure ventilation if breathing is inadequate. Chronic obstructive pulmonary disease, or COPD. It includes emphysema and chronic bronchitis. It also includes asthma. Patients may be on oxygen at home, and the patient usually presents with respiratory distress and use of accessory muscles. So let's review COPD. The two that they list here: emphysema is going to be the collapse or inflammation or the clogging up, with mucus and stuff of the alveoli. So emphysema is going to affect the alveoli more. And then chronic bronchitis, bronchi, we think of the bronchioles, those tubes that attach to the alveoli, or that the alveoli attach to, can become inflamed, constricted, or back up with a lot of mucus and fluid. So that's the difference. One is the alveoli, one is bronchitis. One is your bronchi. Maintain the SpO2 at or over 94%. If the patient has an inhaler, follow your protocols for assisting the patient with its use. If the patient cannot maintain the SpO2 at or over 94, consider CPAP according to protocol. There's nothing wrong with contacting medical direction if you have a question about what treatment to use. All right, altered mental status. It may be chronic or a new onset. It can range from confusion to unresponsiveness. Do not assume altered mental status is normal for a patient. Even when we are out here, some patients, a lot of your nursing home geriatric patients, we had a patient where she thought she was 98, but she was really 96. I wouldn't call that altered. I would call that more of a dementia, Alzheimer's type condition. She's not altered. She just thinks the dementia set in and she thinks she's a certain age. But other than that, she was alert and oriented. So don't think that just because they may think they're 98, they may think they're a different age or whatever, that they're altered. You need to ask questions about dementia and Alzheimer's and things like that. So, altered mental status may be chronic or new onset. It can range from confusion to unresponsiveness. Do not assume altered mental status is normal for a patient. Okay, AMS in the middle. Look up, we have head injury, cardiac dysrhythmias, and acute coronary syndromes. And these are your common causes. Delirium, dementia, and Alzheimer's disease. Seizure, infection, medication or drug toxicity, shock or severe dehydration, hypoxia and respiratory disorders, hypothermia and hyperthermia, stroke and TIA, blood glucose abnormality. So, delirium, dementia, and Alzheimer's disease is listed on these common causes of altered mental status, but I still want you to make sure that you understand there is a difference between someone who's demented and someone who is altered. I can have a dementia patient who thinks they're a different age than what they really are, and I'm okay with giving them like oral glucose or something because they still have a gag reflex and they're alert and oriented, rather than that altered mental status where I would be kind of iffy about giving them oral glucose because they may get worse and not have a gag reflex and choke. Okay, cognitive impairment under altered mental status. There is a deterioration of the geriatric person's thinking, memory, language, and judgment skills. Recognize the patient who doesn't have the ability to take care of himself. All right, stroke. It may be ischemic or hemorrhagic. Remember, that's a blockage or excessive bleeding. Intracranial pressure may be increased. It may result in an altered mental status ranging from disorientation to unresponsiveness. The extent and location of the stroke affects the severity of altered mental status from lightly disoriented to totally unresponsive. A massive stroke can lead to death within minutes. Your treatment's going to be recognition. That's very, very important because time is of the essence. Protect the airway. Without an airway, we have nothing. Maintain an SpO2 greater than or equal to 94%. Transport into Fowler's conscious or lateral recumbent unconscious. A TIA or a transient ischemic attack. It has the same presentation as a stroke, but signs and symptoms resolve within 24 hours. Treat similarly as for a stroke. The TIA is often the precursor of a stroke. Seizure. Common causes include cardiac arrest, low blood sugar, tumors, head trauma, stroke or TIA, infection, and electrolyte imbalance. Infection, ask yourself what would cause a seizure and an infection, we're going to be thinking more along the lines of a fever. Okay, treatment is the same for younger patients and seizures. Monitor the airway, suction as needed, maintain an SpO2 greater than or equal to 94%, provide positive pressure ventilation if breathing is inadequate. Syncope. This is very common in geriatric patients. It's a temporary loss of consciousness from an interruption of blood flow to the brain because their body and their arteries and blood vessels are deteriorating. They're more likely and more susceptible to syncope. Consider spine motion restriction if the patient fell. Remember, you need to ask those questions. Did you fall, hit your head? Okay. Ensure an adequate airway. Maintain an SpO2 greater than or equal to 94%. Apply positive pressure ventilation if breathing is inadequate. Place an unresponsive patient in the recovery position. All right, hyperosmolar hyperglycemic syndrome, HHS, is a complication of diabetes. Blood glucose rises, but enough insulin is present to allow glucose to be used for energy so that ketones are not produced. Dehydration occurs from excessive urination. So HHS is going to be in your type 2 diabetics, not your type 1. Type 1 is your diabetic ketoacidosis syndrome, and which is different because the body produces ketones because there's not enough insulin. Signs and symptoms have a gradual onset. The blood glucose level is elevated. Other findings include polydipsia, polyuria, dry mucous membranes, dizziness, confusion, and seizures. Way to treat it is maintain the airway, maintain an SpO2 greater than or equal to 94%, and consider ALS intercept. Remember, this is someone with a high blood sugar. We are not giving oral glucose. Drug toxicity. Remember, geriatrics, most geriatrics take a lot of medication. Drug interactions, adverse effects, and toxicity are more common in a geriatric. Treatment includes maintaining an airway and ensuring adequate ventilation and oxygenation. Transport all medications with the patient. Delirium and dementia. Dementia is a chronic, irreversible deterioration in mental function that occurs in about 15% of the geriatric. Management is just supportive. Delirium is an alteration in mental function with a recent and sudden onset. It indicates an underlying disturbance of the body systems. Consider causes such as low blood glucose levels. Management is supportive. So this is gradual. Dementia is chronic and gradual. And delirium is an acute. It's acute, so it's going to come on a little bit quicker. Alzheimer's disease is the most common cause of dementia in the geriatric patient. Patients may be uncooperative. This is an indication of the disease, not a personal attack. You're gonna know that something's off, and they're not where they're supposed to be, or they're not acting like they normally do, and they're gonna totally disagree with you. They're gonna tell you they're normal, and they don't understand why you're asking all these questions or why you're trying to make them do certain things. You may need to repeat information because usually the conversations they're having, you ask them a question, they've already forgotten what you asked, so you might have to repeat yourself. Signs of trauma and shock. Trauma is a leading cause of death in the geriatric. Several physiological changes increase the risk of trauma. Falls are common, the common cause of trauma deaths in a geriatric patient. Consider the events that may have resulted in trauma, such as dizziness, faintness, and palpitations. The geriatric are much less able to compensate for the effects of trauma and can deteriorate rapidly. Treatment: provide spine motion restriction if indicated. Ensure inadequate airway, oxygenation, and ventilation. Treat and transport the patient expeditiously. GI bleeding: common cause and potentially life-threatening. Indicates an underlying disease process, maybe from the upper or lower GI tract, maybe obvious or occult. Occult means you can't really tell, and maybe associated with abdominal pain. You probably can't diagnose what the cause is, but you still need to get them to the hospital so that they can figure it out. For your treatment for GI bleeding, be alert to signs of shock, maintain the airway, and ensure adequate breathing and oxygenation. Position the patient in the recovery position. A blood pressure that is 10 millimeters of mercury lower when the patient is standing than when they are supine indicates volume depletion. So this is where you need to do your orthostatic vital signs. If you don't know what that means, go look it up because we've talked about it before. So orthostatic vital signs. Environmental temperature extremes. The ability of the geriatric to create heat when cold or to dissipate heat when hot can be impaired from the aging process, diseases, and medications. Hypothermia or hyperthermia may result. Okay, elder and geriatric abuse. It includes neglect, physical abuse, sexual abuse, financial abuse, and emotional abuse. Elderly who are bedridden, demented, incontinent, frail, or have disrupted sleep patterns are at a higher risk. These people are going to require someone to come sit with them, maybe a family member, maybe someone that's hired. And unfortunately, there are bad people out there that will take advantage of and abuse these patients. It's very, very sad, but it does happen. So you need to kind of, in your mind, be thinking about that if you go on scene and there's certain things that you witness. Okay. And remember, you are a mandatory reporter, so you need to report these things to the proper authorities. Physical abuse to anyone over 70 years old is called injury to the infirmed, and it is considered a felony in the state of Louisiana. Your priority is to provide emergency care for the injuries. Do not confront the family or care provider with your suspicion of abuse because they may be the ones abusing the patient. Make your suspicion known to the receiving hospital. Follow protocols regarding reporting suspected abuse. Okay, click on the underlying cause of hyperglycemic hyperosmolar non-ketotic syndrome. I'll give you a second to check that out. Okay, if you chose D, type 2 diabetes, you would be correct. Hyperglycemic hyperosmolar non-ketotic syndrome is a complication of type 2 diabetes. Remember, type 1 diabetes is going to produce diabetic ketoacidosis syndrome. Oops. All right. Okay, Vic immediately stabilizes the cervical spine and performs a primary assessment. He notes that the patient's respiratory rate is about 24 per minute and shallow. She has a radial pulse of 88, a radial pulse of 88, and it is irregular. The patient is agitated and cannot remember that Vic has explained what happened and what he is doing. Meanwhile, Tina has placed an oxygen mask on the patient. An engine crew has arrived and has prepared a long backboard. What are some potential causes of altered mental status in this patient? What special considerations are there in spine motion restriction? And what additional assessment information do the EMTs need? I'll go back to the case study for a second. All right, here are the questions. I can encourage you to write them down. All right. Assessment-based approach in a geriatric patient. The population over age of 65 is increasing. The geriatric deserve respect. EMTs must avoid ageism, so don't neglect them because they're old. The geriatric have a number of social issues, including isolation, loss of loved ones, and financial difficulty. The geriatric can be found in a variety of living situations. Advanced directives should be considered when caring for the geriatric. Elderly who are at a particular risk are those who live alone, are incontinent, are immobile, have been recently hospitalized, have been recently bereaved, and have an altered mental status. During your scene size-up, assess for hazards, including the possibility of infectious disease. Assess the environment, including the temperature. Determine if the problem is medical, traumatic, or combined. And look for clues to the problem. All right, so there on the left you have clues. The bucket next to the bed, the patient suffers from nausea and vomiting. Hospital bed, they have no or limited mobility and pre-existing chronic illness. And the list goes on. You need to look at this list and kind of be familiar with it. Okay. One of the important ones about this chart are medications found at the scene is a clue about the patient's pre-existing conditions. Tripod position. If you find the patient there in the tripod position, the patient has significant respiratory distress. All right. Primary assessment, mental status. Establish a baseline mental status. Ask caregivers to describe the patient's usual status. So you may think that they're totally off, but their caregiver may say, nope, this is just how they normally are. Okay? So if that's the case, then you know that nothing has changed, so you don't have anything to be concerned about. The geriatric may process information more slowly. The stress of an emergency or change in the environment can cause confusion. A sudden altered mental status is not normal. Hypoxia is a cause of agitation. High levels of carbon dioxide can cause confusion. Poor brain perfusion can cause altered mental status. Dehydration, infection, altered blood glucose levels, hypothermia, stroke and head trauma, and drugs or alcohol. Okay, airway in your primary. There's an increased risk of choking and aspiration. Arthritis and dentures can complicate airway management. Breathing and oxygenation. Elderly patients have a higher resting respiratory rates and lower tidal volumes. Retractions are less likely in respiratory distress. Fatigue can occur easily in respiratory distress. Maintain the SpO2 greater than or equal to 94%. Use positive pressure ventilation if breathing is inadequate. Circulation. Assess central and peripheral pulses, noting the rate, strength, and rhythm. Resting heart rates are higher unless the patient is on beta blockers. And irregular pulse is common in the geriatric. Skin. The skin is normally drier and less elastic. Check the mucous membranes for signs of dehydration. Determine transport priority. Is the patient stable or unstable? Any patient with abnormality of the airway, breathing, circulation, or mental status is unstable. During your secondary, sensory changes may affect history taking. Position yourself so the patient can see you and explain what you are doing. It's kind of like treating a child. You need to get on their level, explain what you're doing to them, and so get where they can see you. If the patient has eyeglasses, make sure they have them. Cataracts and glaucoma decrease tolerance for bright lights and glare. Do not assume the patient is deaf. If the patient has a hearing aid, make sure that it is turned on. Do not shout. Note writing may help if the patient is hearing impaired. For the geriatric trauma patient, the geriatric are at a greater risk for injury. Decreased pain sensation can make absence of pain an unreliable finding. Maintain a high index of suspicion for injury. For the medical patient, chronic diseases or medications can mask or alter the presentation of signs and symptoms. The patient's memory and orientation can affect history taking. There may be multiple complaints. Okay, special considerations and vital signs of the elderly. The respiratory rate is normally higher in the elderly. The resting heart rate is normally greater than 90 beats per minute unless influenced by medications. Skin is normally dry and less elastic. Fever is less common in the elderly, even when a serious infectious disease is present. The systolic blood pressure increases in the elderly patient, making systolic hypertension more common. The hypertension might give a false reading if the patient who has lost blood or who is dehydrated. However, the blood pressure will fall quickly because the patient cannot compensate well. The pupils are more sluggish to respond to light because of the normal aging process. The pupils might be distorted, not round, because of cataract surgery or other conditions. Eye drops that the patient may be taking for conditions such as glaucoma can cause the pupils to dilate and not react normally to light. So talk to the patient rather than talking about the patient to others. I can almost guarantee you that the other people around you are going to chime in. All right, still on the medical patient. In the history and exam, remember the patient may become fatigued easily. To explain what you're doing, explain what you're going to do before you do it. I don't know why these people write these slides like this, but whatever. The patient may minimize or deny symptoms, and peripheral pulses may be difficult to evaluate. You should anticipate the geriatric patient might not report or fully report all complaints. You should elicit as much information as you can. During your exam, address the patient as Mr., Mrs., Miss, or Miss. Remove layers of clothing as necessary. Perform a complete secondary assessment on patients who have an altered mental status. And perform a complete secondary exam on trauma patients. Emergency medical care and reassessment. Anticipate problems and reassess continually. Maintain patient's airway. Be prepared to assist ventilations and maintain adequate oxygenation. Determine the best position for transport. All right, TINA performs a rapid secondary assessment and is concerned to find crepitus to palpation over the patient's anterior chest wall. En route, the patient's vital signs are heart rate 96 and irregular, respiratory rate 28 and shallow, blood pressure 128/88, SpO2 is 88% with a non-rebreather mask at 15 liters per minute. The patient's mental status worsens as she is more agitated and confused. Vic prepares to assist her ventilations with a bag valve mask as Tina notifies the receiving hospital. I'll kind of insert a joke here, but I'm wondering who's driving. If he's preparing ventilations with a BVM and she's notifying the receiving hospital. Anyway, it must be a team of 3. The patient is found to have multiple rib fractures and a pulmonary contusion, and she is placed on a ventilator and admitted to critical care. All right, our lesson summary. All body systems are affected by aging. Aging of body systems affects the ability to compensate for illness and injury. Signs and symptoms of illness and injury may be diminished in the geriatric patient. Medical problems, trauma, exposure to environmental extremes, and abuse are common geriatric problems. Social and financial considerations complicate the health of the geriatric. Always treat the geriatric with respect. All right, that concludes this lesson. I will see you next time.